Good morning, everyone. Thanks for coming. We're going to go ahead and get started. My name is Michael Sutker. I'm one of the general surgeons here at Medical City Dallas. Giving this talk with Dr. Bell, who's one of our other general surgeons. And we're here to learn a little bit about hernias and robotic surgery. So I'm going to kind of give just an overview about hernias and how we diagnose them and how we treat them. And then Dr. Bell is going to go into a little bit more detail about the surgery itself. And then we have the Vinci robot here to kind of demonstrate as well. So what I'm going to go through is exactly what is a hernia, what causes a hernia, how do we diagnose them, what are the symptoms, how do we treat them, and then if you have surgery, what's the recovery afterwards, and then ultimately what are some of the risks involved with having a surgery. Also feel free to stop me at any time if you guys have questions. I want this to be interactive, so don't hesitate to raise your hand and ask away. So a hernia is basically an abnormal protrusion through your abdominal wall. You've got different tissue layers in your abdomen. You've got skin, you've got fat, and you've got muscle. And when there's a hole in that muscle, that's what a hernia is. Hernias can be pretty much located anywhere in your abdominal wall. They could be in your groin, what we call an inguinal or a femoral hernia. They can be at your belly button, what we call an umbilical hernia. They can be in the midline of your abdomen, what we call a ventral hernia, and a subtype of that is an incisional hernia. So if you've had a previous operation with a big incision, you can get a hernia there. You can also have them in your diaphragm, what we call a hiatal hernia. And then there's other kind of rare sorts of hernias, like what we call sports hernias, which can also be just chronic groin pain. And then you can also get them in your back or your flank, etc. So pretty much anywhere around your trunk, you can get a hernia. This is just a little picture. So about 75% of hernias that we see are of the inguinal variety. They're a groin hernia. About 10% are in an incision or a ventral hernia, and then about 3% are umbilical hernias. So the most common ones that we see by far are inguinal hernias. So how do you get these? And we kind of divide them into two categories. The first are congenital, meaning it's something you're born with, and the second risk is acquired. So congenital are ones that we see in infants and toddlers. Those are the ones where kids get them fixed at 6 months, 2 years old, etc. And those can sometimes persist even into the teenage years. Most of the ones that we deal with as a surgeon are acquired. And pretty much anything that can increase tension in your abdominal wall or increase pressure in your abdominal wall can cause a hernia. So people who do repetitive heavy lifting, people who do a lot of manual labor, people who are bodybuilders, that puts strain on their abdominal wall. Smokers with a chronic cough that are chronically coughing and pushing, those people get hernias. People with constipation that are constantly having to strain to have bowel movements, that can cause a hernia. Men with prostate problems that are having to strain to urinate, that can cause a hernia. And the women who are pregnant, they get lots of stretching, lots of pressure in their abdominal wall. It's relatively common for women to get belly button hernias during pregnancy. Sometimes those go away after pregnancy, but a lot of times they persist and need to get repaired later on. And then probably the most common thing that we see these days is obesity, is being overweight, having extra fat in your abdominal wall puts constant pressure and puts you at risk for forming hernias. Yes, sir? The only time it goes away is after pregnancy because of the changes of the abdominal wall for women where they stretch and then they go away. Beyond that, if you have a hernia, it's never going away without a repair. Very good question, though. So what are the symptoms? The vast majority of hernias are asymptomatic, meaning you may not even know that they exist there. A lot of times patients come to see us because their primary care doctor was doing just an exam, a routine exam, or they were having a physical done at work and this was picked up and someone said, "Oh, did you know you have a hernia?" And the answer is no, but why don't you go see a surgeon for evaluation? But the kind of symptoms that people do get, the first is noticing a lump or a bump or some swelling where it's not supposed to be. Occasionally people do a forced activity and all of a sudden feel pain, feel a bulge, feel something uncomfortable. It doesn't mean that the hernia just started, but that they just noticed it is typically more what happens. And the other thing is some people just complain of constant discomfort, a dull, achy pain, not any like sharp shooting pain, but I just don't feel well, I have a little bloating, I have a little nausea, and then they notice a bulge associated with that. We kind of divide hernias into two categories, being reducible and irreducible. So reducible hernia is one you can push back in. Those are typically managed in an elective setting. The non-reducible hernias, or the incarcerated hernias, the ones that we worry about more as an emergency, where something is sticking out through that hole and it's not going in, it's trapped there. And we'll talk about sort of the risks a little bit. The thing that we really worry about with hernias is the bowel or the intestines getting trapped in that hole, and that's an emergency, that's a bowel obstruction. And what's even worse than that is sometimes it can get so trapped and clogged that it compromises the blood supply and lead to what we call ischemia, where it causes the piece of bowel or the piece of intestine to die off. And that's truly an emergency because you can get a rupture or perforation associated with that. So the reason to fix hernias earlier is so we don't have to deal with these complications. Little tiny hernias typically don't cause problems because nothing can slip into them. Big giant hernias don't cause problems because things can typically slip in out of them. It's the medium-sized hernias that are big enough for something to go in but then not come out. So typically a hernia is diagnosed with physical exam alone, meaning you come in to see us, we feel your belly, we feel your groin, and we notice a hernia there. Occasionally, a hernia will be picked up incidentally on a CT scan, whether you're having a scan for appendicitis or for a gallbladder problem, and then you see an inguinal hernia or a little belly button hernia. For big giant hernias, sometimes we'll get a CT scan to get a better understanding of the abdominal wall, but for routine belly button hernias, routine groin hernias, typically no imaging is required, and it's physical exam alone. So the track to take with evaluation of hernias is, do we operate or do we wait? And so they did a study out at the VA where they randomized people. It said one group of people gets waiting, one people gets surgery off the bat. And they watched those people for 2 years. The risk of waiting and the risk of surgery were about the same. So even if you waited 2 years, you weren't at higher risk of having a complication. That being said, when they've done studies like this, up to 3 in 4 patients still go on to get their hernias fixed because they do tend to get larger, they tend to get more painful and more symptomatic, so most people want to go ahead and get them fixed anyways. Hernias are typically easier, or technically easier to fix when they're smaller, when they're less symptomatic, and the chance of a complication is a lot less the earlier you fix them. So reasons to operate, number one, you have a hernia. So if you come in, you say, I have a hernia, even though I don't have symptoms, that's a very good reason to operate. And if you say, well, I have a hernia, but I have no symptoms, I want to wait, well, when symptoms start, that would be the time to operate. As I said, the procedure itself, Dr. Bell is going to talk about in a little bit more detail, but typically it's a day surgery procedure. You come in the morning, go home in the afternoon. If you're doing a groin hernia, it takes about an hour. If we're doing both sides, that takes about an hour and a half. For a belly button hernia, if we're doing it with a little open incision, that takes about 30 minutes. If we're doing it on the robot, that can take about an hour. And then if you've got a ventral hernia or a larger hernia, that takes about an hour or so. The vast majority of patients go home that same day after surgery. For most people, taking off somewhere between 3 and 10 business days of work, especially if you're doing light duty, a desk job, etc. If you're doing some kind of manual labor with a lot of lifting on your feet all day, it may be 2 to 4 weeks off of work depending on what your job responsibilities are. Essentially, we want to let your belly rest so that you don't get a recurrence, that this doesn't come back again. Any straining in that initial period can put your hernia repair at risk, and obviously we don't want to do that. Just general everyday activities like getting in and out of bed, in and out of a car, up and down stairs, all that is fine. If you want to do cardio activities like running, jogging, biking, elliptical machine, that's pretty much safe to start whenever you feel comfortable. People do feel really fatigued after surgery, so you may not feel up to it initially, but you certainly can start whenever you feel fine. Things like strenuous activities, and the 3 most common things that people ask us about are, when can I start weightlifting? When can I go back and play golf? And when can I resume sexual activities? And essentially, probably wait about 2 weeks till you see us in the office, but let pain be your guide with any activity. If it hurts, don't do it. And if it doesn't hurt, then you're pretty much safe to resume as you feel comfortable. A little bit of discomfort, a little bit of soreness is okay, but pain, especially if it makes you stop what you're doing, don't work through pain, at least not in the first initial period. So what are the risks of surgery? We know we can do these operations really safely. This is probably the second or third most common procedure that we do as general surgeons. The first two being gallbladders and appendixes. Hernias are typically number 3. The thing that we worry about most is a recurrence, meaning this comes back again in the future. The risk with a groin hernia is probably about 2 to 3% of hernias come back over time. Over time can be 5 years, 10 years, 20 years. We commonly see people who have had open inguinal hernia repairs 20 or 30 years in the past, then come back with another one. With the laparoscopic repair, with placing mesh, I think that risk is a little bit decreased, but it's not zero. If you do a repair of any of these big hernias without mesh, which is a question we commonly get asked, the recurrence rate is probably at least 30%. So that's why we strongly recommend placing mesh so that this doesn't come back again in the future. Specific risk factors for this coming back are obesity, so being overweight because you're just carrying around that extra strain. And the second one is smoking. Smoking puts you at risk for wound complications and healing problems where your hernia is likely to come back. Probably the umbilical repair is actually a higher recurrence rate than a groin hernia. So, especially because a lot of umbilical hernia repairs are done without mesh. And so I think the recurrence rate's a little bit higher. Other things that we worry about are chronic pain, especially with groin hernias. That risk may be up to 10% having some chronic pain or discomfort. Sometimes that's related to just inflammation. Sometimes it's related to nerve entrapment. If pain is your presenting symptom, so you're coming in not with a bulge, not with obstructive symptoms, but with pain, the risk of having chronic pain is a little bit higher in those patients than someone who doesn't come in with much pain or discomfort. The mesh is essentially permanent that we put in there. The risk of infection is about 2 to 3 in 1,000, and that's typically the only reason why we would ever go in and remove it in the future. And then in men, the other things that we worry about are damage to the spermatic cord, which runs right where the inguinal hernia is. And that can lead to things like testicular pain or infertility if those structures are damaged. Yes, sir. Yep. So typically the mesh that we use for hernias has not been a significant liability. Most of the advertisements you see are a lot for women who have had bladder slings and have mesh placed in their pelvis that is exposed to bowel and exposed to bladder, and not places that we typically are as general surgeons. That being said, I've had very good experience with mesh. I can't remember a specific patient off the top of my head that's gotten chronic pain or chronic infection related to it. But I've definitely gotten in the situation where I haven't put it in and a patient's got a recurrence of their hernia, and that's typically a worse problem. Hernias are typically relatively easy to fix the first time around. When you're talking about a second or a third or a fourth recurrence, that's when things get a lot trickier. I'll give the example. My dad needed an inguinal hernia repair. I would have not told him to do it without mesh. I would have definitely said put mesh in, because it's essentially been the standard repair for about 30 years. So we have really good results with that. In men, one of the other risks with groin hernias is and in women a little bit, is getting urinary retention, meaning having difficulty peeing afterwards. We always make sure before you leave the hospital that you're able to pee okay. If not, the worst case scenario is you get a catheter put in your bladder for a day or two, and then that comes out. That's something that always gets better, but occasionally you can get some bladder spasm after having the repair. Other risks of surgery include things like wound infections, bleeding, scarring, blood clots. Those are kind of standard. It doesn't matter whether I'm fixing your hernia, taking out your gallbladder, taking out your appendix. Those are all pretty common risks of surgery. So that's kind of a very brief overview of hernias. As I said, Dr. Bell's going to talk a little bit about the procedure itself. Anyone have any other questions at this point? Yes, ma'am.
So, piggybacking on his mesh,
Yep.
so there's an issue like 10 years down the road.
Yep.
You got to come back.
Yep.
How do you fix the mesh problem?
So, I mean, we see that people with recurrences that already have a mesh in place, typically you can remove the mesh with relative ease and then repair it with a different piece or different kind, etc. They make advancements in mesh technology all the time. So every year, every 2 years, we get something new and different, and they do studies on all this. So, the mesh that I use now is different than what I used 5 years ago, and that doesn't mean what I used 5 years ago was bad. It just means that the technology has gotten better, that they've done more studies to prove what is better or what may last longer.
Has anyone ever come back and had the mesh taken out, decided not to put mesh back in?
The only instance we do that is if someone gets an infection, either in their belly or in the mesh itself. That would be a reason to take it out and leave it out. And when I do that, I always caution patients, it's likely your hernia is going to come back in that situation, and then you're going to need another repair when you don't have an infection with a mesh. So, yeah. Yes, sir. I have gone a lot more so towards mesh in almost every situation. I've had a much higher recurrence rate. It's still low. I don't want to say that I've had complications or anything, but it's much lower when I put mesh in, especially in patients who are a little overweight. That risk, I think, is higher. Okay, so hiatal hernia, Dr. Bell is actually going to address that a little bit more. So, and that's honestly, it's going to be a topic for another time. Hiatal hernias are a little bit different than inguinal hernias and ventral hernias because it's a different part of the abdominal wall. But we still fix them with the robot laparoscopically. So, Chris, did you say you were going to talk about that a little bit or no? Okay, all right. He'll address that a little bit more. Okay. All right. Well, I appreciate the time. We really appreciate you guys coming out, and I'll turn it over.
All right. I wanted to thank everybody for coming out this morning, and my topic is going to be a little bit more about the operation itself, how it's done, and the rationale behind minimally invasive and especially robotic surgery. My name is Chris Bell. I'm in practice with Dr. Sutker, and we both operate on hernias quite a bit, and happy to talk to you about this technology. I wanted to start off by saying there are different ways to repair hernias. The older, more traditional approach is open, and so that's making an incision over the hernia. Newer techniques are called minimally invasive surgery, and that would be laparoscopy. And robotic surgery is a form of laparoscopic surgery. And I'll be showing you a little bit about the robot and the rationale behind why we use the robot in surgery today. Just to tell you a little bit about me, I've been in practice here since 2006. I did a fellowship in minimally invasive surgery similar to Dr. Sutker in a 4-surgeon practice. And I've gone more towards robotic surgery as a form of laparoscopic surgery in the last few years, and it's been a great way to operate. That's a picture of my residency class back at Parkland, and this is a picture of our practice. Dr. Jang is second from the left. She also does robotic surgery. Dr. Lane on the left has recently retired, and we've added a new surgeon, Dr. Hinke, who's not in this picture. And we'll be adding another surgeon on Monday. So we'll have a 5-surgeon practice. All of us use the Vinci robotic system to treat patients. A little bit about the robotic program at Medical City. Many specialties use Da Vinci robots. This is the XI robot, the most current iteration of the robotic surgery platform. And we currently have 5 robots. Different specialties use them, not only general surgery, but also OB-GYN and urology. A lot of patients will have prostate surgery robotically with a urologist, and in a similar fashion, a lot of patients will have a hysterectomy with OB-GYN doctors using the same technology. This is a picture of the Da Vinci robotic system. The part that has the 4 arms is called the cart, and it's the part that actually moves, and the console is the part that you see over here on the right. The surgeon sits there at the console. I just want to point out that the console is in the same room. It's not in a separate area, so the surgeon is next to the patient, and so that's something that just to point out. As you might imagine, there's been different iterations of the Da Vinci robot. The current one is the XI, and right now we have 5 of them here. As far as the history of robotic surgery, this early interest was with heart surgery, with valve surgery, and over the years it evolved into prostate surgery and hysterectomy, and now general surgery is one of the fastest growing specialties for Intuitive, which is a company that makes a Da Vinci robot. We see early in 2004 prostate surgery, hysterectomies, lung surgery, ventral hernias, and inguinal hernias were being done. But as time went on in 2017, you can see at the bottom, hernia surgery really became more popular with the Da Vinci system. In 2017, there were 877,000 robotic procedures in the US, and this represents an increase of 16% worldwide. And a lot of this is due to general surgery and hernia procedures. So you might be asking, well, why would a surgeon use a robot? Why not just do the operation laparoscopically with traditional instruments? So as you'll see today, and I'll be happy to demonstrate later on, the instruments have wrists on them. So they're very similar to a human hand or a surgeon's hand. So they're able to move in many directions, which is different from a laparoscopic instrument that would only move in 2 dimensions. So the instruments actually move in a hand-like motion. The other thing that's very nice about robotic surgery is that you have the ability to see the anatomy in a 3-dimensional view. So this is different from laparoscopic surgery where it's a 2-dimensional view. In robotic surgery, it's almost as if you're inside the abdomen in a 3-dimensional view of the anatomy. You can see in this heat map the growth of hernia surgery with Da Vinci. The top slide is 2012 versus 2016, and you can see that it has really become more and more popular. And I think it's because the results have been excellent, and it's because the operation can be done by the surgeon in an easier fashion because of the instrumentation and because of the better visualization. This slide talks about the predicted growth with Da Vinci hernia, and you can see over the past few years it has really trended upward. We've seen this at Medical City too. We've seen starting several years ago a real increase in the amount of robotic general surgery that's being done. The dark blue bars, the navy blue bars demonstrate general surgery, and the other specialties are represented in gray and red. So just a little bit about laparoscopic surgery and robotic surgery. When we do robotic surgery or laparoscopic surgery, we use a gas called CO2, and that is placed inside the abdomen, and that distends the abdominal wall so that the instruments have room to work. After the surgery is completed, that CO2 gas is released, and the abdominal wall goes back down to its normal state. So there are different types of surgeries that are done, not only hernia surgery, but gallbladder surgery. We do weight loss surgery with the robot. Hiatal hernias, which Dr. Sutker talked a little bit about, are also done with the Da Vinci robotic system. So a hiatal hernia is where the stomach is above the diaphragm, and it should be below the diaphragm. And when you have a hiatal hernia, you can have reflux, difficulty eating, and so that can definitely be repaired with a Da Vinci robot, and we do that not infrequently. Other operations which are less common, adrenal surgery and also gastric pacemakers and various other operations can be done with this. One of the nice things about inguinal hernia surgery with the Da Vinci system is that the mesh that we use to repair the hernias can be placed and we don't have to use a tacking device, so there's no metal clips, which is I think a real benefit of the Da Vinci system. So the Da Vinci allows us to suture because of the wristed instruments, and so the mesh is placed, the tissues can be sutured, and I think that is a real benefit compared to laparoscopic surgery where tacks and other devices are used to fix the mesh. Okay, I wanted to show you all a little bit about how the operation is done. And so for patients who have inguinal hernias or the groin hernias, we do not actually place the incisions at that location. We place them in the abdomen, and this is because we need a little bit of space to work. And so the mesh is actually placed underneath the hole or the defect, and it's very similar. I always tell my patients it's like patching a tire from the inside of a tire. And so the approach is from below. So for an inguinal hernia, we use 3 incisions. These devices that are going through the abdominal wall are called trocars, and they connect to the arms of the robot. And the one in the middle is used for the camera. The ones on the sides are the surgeon's left and right hands, if you will. And you can see that gas hose that's attached to the middle trocar. That's where we use CO2 to inflate the abdomen. This is just a little bit about inguinal hernia anatomy, so that basically what we're doing is we're looking for the opening or the hole in the pelvis that is the hernia. And so through that opening you can have intestine or a hernia sac, and so that's reduced and mesh is placed. And so this is the view that we'll see at surgery. This is a little bit about the inguinal ligament. Hernia sacs can occur in the inguinal canal. And this is just some anatomy that Dr. Sutker reviewed some of this as well. This is what mesh looks like. There's different types of mesh. Most of us use the mesh product on the left, which is called ProGrip. This is a nice mesh that we've had very good results with, and the thing that I like about this mesh is that the mesh is self-fixating. You can think of a piece of Velcro almost, so it basically covers the hole or the hernia and stays in that position, and so this mesh does not require fixation, and so it's a nice way to go, and I think leads to reduced pain after surgery because you don't have to use tacks or any kind of fixation device for this. Another excellent mesh that I used to use years ago is on the right, and it's called 3D Max, and it kind of reminds me of a contact lens because it's concave. And these meshes are pretty large. They're about 10 to 15 centimeters, so you can think about a note card. So you want the mesh to be actually larger than the hernia so that recurrence is low. This is a view of the abdomen, what the surgeon sees, and you can see that we are in the peritoneal cavity. We can see the intestines. We can see both sides. The nice thing about robotic surgery is we're able to see the left and the right side, and so if a patient has a hernia on both sides, that we can repair both through the same 3 incisions, which is very nice. This is a little bit more detailed view of the anatomy. The hernia is located, let me see if I can point this out. In this area here. And so the mesh would be placed over that. So this is a video of the mesh placement, and so the mesh is placed. You may be wondering, well, how do you get the mesh in there through these 3 little incisions? And so we place it rolled up, and then we unfurl it or unroll it once it's in place. And so that's how a lot of patients ask me that, like, well, how do you get this in there? And that's exactly how we do it. So you can see the mesh is placed over the hernia defect. We make sure it's nice and flat. And this is a video of how we suture with the robot. So we close the peritoneum or the tissue over the mesh, and you can see the wristed instruments really allow the surgeon to suture very easily. There are other types of hernias that we repair. One is called a ventral hernia. Dr. Sutker mentioned that we see that about 10% of the time, so they're not as common as inguinal hernias. And so for this, the trocar placement or the incisions are actually placed on the side rather than across the midline. So for a ventral hernia, this is a hernia that occurs in the middle of the abdomen. We can actually close the hernia with sutures, and then we place a mesh over the closed defect. And so this is a picture of the mesh that we use, and we use the wristed instruments to suture the mesh in. Once again, a nice way to go because we don't use tacks or metal fixation devices, and so we've had some very good results with this. I wanted to tell you one of the highlights of our program here at Medical City are the people we work with. We're very fortunate to have some outstanding nurses, anesthesiologists, and techs, and this is a picture of some of our robotic staff here at Medical City. These individuals take a lot of pride in the program, and they do an awesome job. And I just wanted to point out they are some of the all-stars of the hospital. So. And I'd be happy to take any questions.
Pregnancy-induced hernia. Okay, so you stop having children and surprise you're going to have a child.
Mm-hmm.
You've already had the hernia repaired.
Yeah, so
Happen if the pregnancy causes an issue.
yeah. So the question is, in a patient who's had a hernia surgery, who will become pregnant in the future, will the hernia come back? Is that? I would say that it is not very likely that the hernia will come back. There is a slightly higher risk of that because of two reasons. During pregnancy, the abdominal wall actually distends, and there's also a hormone called progesterone that relaxes muscle, and so that also puts the patient at risk for recurrent hernia. But it really depends on how the hernia was repaired, how complex it was mesh used. And so generally speaking, if a patient's had an umbilical hernia repair with mesh and the defect was not large, most of the time they can get through pregnancy in the future without a recurrence. But it's important to know that it is possible for those two reasons. Because the abdominal wall grows, that's going to put tension on the repair, and also because of the hormonal effects that occur during pregnancy.
Is it encouraged to have a natural delivery or a C-section?
That's a great question. So the question is, would a patient be better off with a C-section or a natural delivery? And I think, generally speaking, I'm not an OB-GYN, but generally speaking, it is better to have a natural delivery. If at all possible. I think C-section occasionally is necessary, but I think generally speaking a natural delivery would be favored, even if you've had a hernia surgery in the past. Yeah, you're welcome. Yes, sir. Yes. Okay, so the question is what kind of hernias can occur up high in the abdomen, and there are two types. Number one is a hiatal hernia. So you know the diaphragm is up high in the abdomen, and it actually is a division between the chest and the abdominal cavity. And so the diaphragm is the barrier. And through that diaphragm there's an opening by which the esophagus goes through to connect with the stomach. And when that opening stretches, a patient can develop what's called a hiatal hernia, and that occurs up high. Another type of hernia that can occur up high is called an epigastric hernia. Patients that have had heart surgery can sometimes develop that at the lower end of their incision, or you could just develop one out of the blue up high, and that is a type of ventral hernia that occurs up high. And those can also be repaired with the robot or open, just depends on how things look. Yes.
Okay, now I have this friend who has an umbilical hernia. I didn't see the place, maybe I missed it, but will you place it, are you on each side with the gas in the middle, or where the lady goes?
Yeah, that's a great question. Let me back up and so in patients that have an umbilical hernia, and let me just point this out. Occur in this area. So we have to place our incisions away from them because we're going to be doing the work underneath the abdominal wall in this area. So we don't want to be right on top of it. So we need enough space to be able to work. So in that situation, we place the incisions on the side. So in inguinal hernias, conversely, we have a slide of that. Inguinal hernias, which are down here, we can place our incisions close to the umbilicus because we know there's no hernia here. So, but yeah, so that question is, for umbilical hernias and ventral hernias, the trocars or the incisions will be on the side.
Does it really matter to the patient? I mean, there's no extra risk depending on the placement?
No, as far as risk, there is no difference in risk in trocar placement. Really, what the surgeon is trying to do is make the operation technically as easy as possible for them. And placing the trocars away from the hernia really allows the repair to be done in an easier fashion. Yes.
Can we discuss cost versus traditional surgery versus robotic surgery? Is it up or low? About the same?
Yeah, this type of surgery is a type of laparoscopic surgery, and so what the hospital, and I may have to ask Ryan for some help on this, but I kind of think that generally speaking, the codes that are used are laparoscopic codes because it is a form of laparoscopy. I do think it is a little bit more expensive than, say, an open repair or a traditional laparoscopic repair. But the benefit to this is quicker return to work, less pain, and shorter hospital stays. And so that's where the payoff really occurs. It may be a little bit more expensive to the insurance companies or for the overall cost, but the patient returns to their normal activity quicker. And so I think, if you kind of look at it that way, it's a benefit. Any other questions? Yes. Yes, the question is the cost of laparoscopy and robotic laparoscopy different? I believe it is more expensive. I don't know how much more, from the hospital's point of view. The surgeon's codes are going to be the same, though, for laparoscopic or robotic. But I think as far as what the hospital may charge may be a little bit higher because the technology is more advanced and there's a lot more engineering and development that has gone into this. And so, but I don't know how much more. I don't know if Ryan. Okay.
There's a nuance to it, basically. The codes are the same. However, 95% of the insurance agencies have contracted rates, so the laparoscopic versus the robotic reimbursement for hospitals is equal. Very few insurance companies that have contracted rates, the hospital can charge you. And for everyone in the bill, charges do not equal payments. So the hospital
Yes.
Someone wants to commit to your practice if you're approved, what's your schedule for actually working someone in a certain day?
Yeah, so the question is how soon can we see patients? We could see patients as early as next week for hernias, and generally speaking, if a patient needs surgery, we can get them on the schedule within a week or two. So we try to accommodate patient schedules, and different doctors in our practice operate different days, but we can generally get people in very quickly and get your surgery done. And we do have our cards here if you all need to come see us. We'll be happy to take care of you. Oh, good question. So the question is about follow-up visits. And so generally speaking, we see patients back at 2 weeks. And during that 2-week period, we ask patients not to do any heavy lifting. I think Dr. Sutker touched on that. We ask patients to walk for exercise, but to refrain from weightlifting or doing any kind of straining as much as possible. And at 2 weeks, at follow-up, we examine the patients, ask how they're doing, make sure that they haven't had any pain or fever, any signs of infection. And then generally we will clear you to go back to regular activity in the next week or so after the 2-week visit. Yes?
Depends on your insurance company. If you have an HMO, then you need to get a referral from your primary care doctor. If you've got a PPO or some Medicare plan, you can just call it off. So it's dependent.
Yeah, that's a great question. So in a chance that a patient has a recurrent hernia, is the robotic approach the way to go? I think it really is determined by what type of surgery they've had in the past. And so that really would require a physical exam and a history and to sort out. But generally speaking, robotic surgery is an excellent way to go for recurrent hernias. I know Dr. Sutker and myself have both operated on patients that have had recurrent hernias, who've had their surgeries, 20 years ago and have developed a new hernia. And, the nice thing about this, once again, is it's minimally invasive. There's no big incisions. And that's, that gets patients back to their lives quicker and is less pain. So if it is possible to do it, we obviously go this way. Of course, there are some hernias that are not appropriate for laparoscopic or robotic surgery, and we do those open if we have to, and it really depends on the size and the complexity of the hernia, but generally speaking, we do go this route first.
My approach on recurrences is typically if you had a hernia. All right, so my typical approach with recurrences is if you've had it done one way, we should probably not do it that same way again. And so typically, and for the most part, robotic procedures, as Dr. Bell said, have picked up over the last 5 to 7 years. So most people coming to see us with recurrences have had open procedures in the past. So we'll typically not do a second open operation, we'll do a robotic operation. I've done recurrences laparoscopically after a previous laparoscopic repair. I've done them open, but in general, I try to take a different approach. So if you've had it done open and it's come back, then I'll try a minimally invasive approach. If you've had a laparoscopic or a robotic procedure and it's come back, then typically I'll switch to an open approach. Just because if you failed one way, unless there's a discrete cause, well, you may still fail again that way the second time.
Okay, so the question is, for a hiatal hernia, when do we recommend surgery? That's a great question, and it really depends on the workup. And usually a patient with a hiatal hernia will have a workup with a gastroenterologist. We do not operate on every patient with a hiatal hernia, and so small hiatal hernias can sometimes be treated medically, and generally hiatal hernias will cause acid reflux. That's the main symptom. And if the reflux is not severe and can be managed medically, then we may not need to do surgery. Now, in complex hiatal hernias where a good part of the stomach has migrated above the diaphragm, those do require surgery, and those patients will have dysphagia, so when they eat, food won't pass through well. They'll have severe reflux. Maybe even the reflux is not being treated medically adequately, so the medicines may still not prevent the reflux, and those patients we operate on. So a lot of patients have hiatal hernias. They're pretty common, but not all of them require surgery. And usually the surgeon and the gastroenterologist will kind of work together to figure out if the patient needs surgery or medical treatment on those.
The one thing about hiatal hernia is if they're not fixed, it's something to be aware of and to be followed over time. We get lots of people who in their 30s or 40s are told they have a hiatal hernia, don't have it fixed, don't worry about it, and then they come back in their 60s and 70s with a half or 3/4 of their stomach up in their chest, and it's a harder surgery, it's a harder recovery, etc. So if you have one and you don't have surgery, it doesn't mean it goes away. It's likely going to get worse as time goes on, and just something that needs to be observed as time goes on and not just put off if symptoms develop. If you could lose 5 to 10 pounds, that helps. But we've definitely done this operation on people who are 350 pounds and haven't had, recurrences. So, we both do weight loss surgery. That's another component of our practice. Weight loss for almost everyone is a good thing. It's not easy, but when we're talking specifically about hernias, even 5 to 10 pounds can help significantly. Actually, yeah. And that's a lot of times what we see is someone comes in with a hernia and we say, unfortunately, you're just too big to be able to have a successful repair. Let's talk about some weight loss, and then we can certainly do those together. All right, so we also all kind of demonstrate, and Dr. Bell can demonstrate, but you guys can also sit down at the robot and play around for a little bit. So I'll sit down and show you what we do.
Any other questions before we wrap up this segment? All right. Appreciate y'all coming out.